I really ask to change my order if you want to follow Alvar, because I think that what my presentation might illustrate some of the points that he was making. The first point is that, yes, I totally agree that a system is extremely important in every disease, and I think that we will demonstrate this, but it's so difficult to build a system, and so important. There are so many factors that we really need to get together. And the most important thing is that, are the slides? Cosio is the Cosio. The most important thing, I think we are lucky that, thank you, that the personalized medicine is that for us doctors, when we see the personalized medicine, means that we are seeing one patient. One patient has the advantage, he has his own phenotype. I mean, that's it. And so we can really work around his own problem and really personalize, and then if you want, get what we learn from one patient into the possibility of a personalized medicine. It might sound pretentious, the title, the change in paradigms in lung diseases, but I think we might have some basis for doing so in alpha-1 antitrypsin. And that's what this subtitle that I include now is the new look at alpha-1 antitrypsin that I think is very interesting. Now, this, again, chance, and chance, Pasteur said that chance is only useful for the thinking mind, and obviously by chance, Laurel and Erickson in 1963, 50 years ago, discovered that, missing this alpha-1 band, globulin band in the protein electrophoresis, really they saw that there were two patients, really, that they had emphysema, that they were linked to that. Interestingly enough, Erickson was the guy who invented or discovered or started using the electrophoresis for the proteins, so he kept on working on this until they found that. So this found that this was related to some emphysema, and Erickson himself later on really discovered and established that this was a genetic abnormality and it was really associated with emphysema. So it was found that, later on in '68 by Janov, that neutrophils really can release the potent proteolytic enzyme, the neutrophil elastase, that, and they linked that to the function of this alpha-1 antitrypsin, and so that this was the idea that all fit together very well. And the paradigm was built in 1963, and again, this is the basis for, perhaps, the biological, the classical paradigm of the emphysema and alpha-1 antitrypsin, that in alpha-1 deficient individuals, the imbalance of neutrophil elastase and anti-elastase produces emphysema. Punto. And today, when you read a paper about alpha-1 antitrypsin, this is the etiology of alpha-1 antitrypsin. And as you know, by extension, was moved into real emphysema. Okay, so what do we know now about this said alpha-1 antitrypsin deficiency, so the most common one that we see? Now, interestingly enough, in Sweden that they are great about doing things like this, they took for about 2-3 years 200,000 newborns, and they did alpha-1 antitrypsin in all of them, one after the other, and they found that 1 in 1,639 individuals out of 200,000 newborns had alpha-1 antitrypsin PI-Z. In the US, later on, it started in Oregon, and then later on it was done again, and the mean in US is 4,455 individuals, one for that. So that is much, much lower, and this means that, interestingly enough, that the gene abnormality started in Sweden or in the Nordic countries. Now, we, because of this, I mean, the alpha-1 antitrypsin, we all thought and knew or decided that was a bad disease because it produces emphysema. Interestingly enough, when, based on this, people start looking around and said, how many alpha-1s are there? And, in the US and the UK, only 4,000, calculating how many, based on this, should be around with this abnormality, how many have been identified? 4 to 5%, only in the US and UK. And in estimate from another 8 countries, they found that only about 40.41% of PIZ have been recognized. It's obvious that there are a lot that we don't see, and this is a problem because, what we usually think about the epidemiology of alpha-1 antitrypsin is that, we see a lot of very bad, or think about the very bad disease, but the problem is that the way we choose the cases is that by looking at index cases, meaning cases that present with the disease, and not, non-index cases are people who are found by screening and so on, and then, if we put them together, the whole idea is very, very different. And one of the things that we know for sure is that the smoking is a main risk factor, but the big variability in the rate of the loss of function is found even in the index cases. So that, again, here we are. We know that a biological abnormality that we can say that is the problem. We know about some manifestation of this abnormality that we think that should come from the biological abnormality, but it's not the case in a regular basis. So here we are talking about the system start to function, if you want, that there are some things that don't work together from the basis. And just to give you an idea of how this is a Swedish and Danish cases, a lot of non-smokers, all of them, men in black, women in white, and you see the FEV1 fall over from age 20. These have been identified as alpha-1 antitrypsin cases, non-smokers, and you see that up to, most of them, up to age 70 or so, do not seem to fall the FEV1, but there is a group that falls the FEV1. Interestingly enough, this is going to be really very different depending of how are they gathered. I mean, if we find them because they have lung disease, you can see that as the age progresses, the FEV1 falls. There are these guys in there. But if they presented because they had other disease or they were screening and by chance they found to have the abnormality, you can see that really the FEV1 does not change at all with age. So really, this is an added idea about the disease, and this initial biological point that we have the elastase, anti-elastase abnormality that should drive the disease, you start thinking, well, maybe it does, but obviously there might be some other factors because it seems like most of the people do not develop the disease. Okay, after years of believing this, I mean, people have started to really notice that said, alpha-1 antitrypsin is an acute site reactant, especially responding to inflammation. And, so maybe there is something else about the alpha-1 antitrypsin other than the elastase and the elastase, and so on. So could that be an anti-inflammatory thing? Well, we know now a lot about the anti-inflammatory functions or inflammatory functions. We know that, I don't know if this is seen well from the back. I mean, I don't know if the lights, Leo, if the lights can be dim a little bit. Leo, can we dim the lights a little bit, or maybe? Anyway, but you see,
It's coming.
Yeah, good, thank you. Anyway, but you see that the alpha-1 antitrypsin is going to block a lot of pro-inflammatory cytokines, chemokines that they are very important, and IL-6, 8, IL-1 beta, TNF-alpha, IL-32 and BAF. I mean, it really actively blocks these things. And at the same time, and this is an amazing thing about this molecule, is that at the same time that it blocks that, is going to really enhance the production of anti-inflammatory molecules like IL-10, 1-beta receptor antagonist, THF-beta, CTL4, and IL-2, interestingly enough. So this is in kind of the basic inflammatory initial response, if you want. But another thing that is going to be very important is the effects of alpha-1 antitrypsin in this other phase of the, meaning once that if there is a presentation of antigens by dendritic cells, what's going to happen? Well, the first thing that's going to happen is that by blocking this and enhancing the other cytokines, the first thing that's going to happen is that indirectly the numbers of stimulation and function of Th1, 2, and 17 is going to be really downregulated, so that no lymphocytes will be active at all. At the same time, because of the IL-2, interestingly enough, is preserved, and because of there is a problem with the dendritic cells, the Tregs are going to be very much enhanced by alpha-1 antitrypsin, and alpha-1 antitrypsin also controls the maturation of the dendritic cells, and by controlling the maturation is going to, meaning not allowing the dendritic cell to maturate, is going to prevent the antigen presentation. And really produce it's not prevent, it's preventing a reaction, immunological reaction to an insult. So obviously, this is some new factor that, again, that we should consider into the possibility of the system, if you want. We have something else that does not exclude the prior abnormality, but certainly make us think that should be something else that we should include it. Now, we were interested really in this phase in saying, could the lack of an anti-inflammatory function in alpha-1 antitrypsin play a role in the development of emphysema COPD in patients with alpha-1 antitrypsin deficiency? Now, we are in Padova extremely fortunate to have a system that works very well, in which clinicians, pathologists, surgeons, and statisticians can really work together and do work together, so that over the years, I mean, Marina and company have been able to collect, in this case, we are analyzing 10 patients with alpha-1 antitrypsin deficiency that had a transplantation of the lung, so we have the whole lung. We have, interestingly enough, 26 people who also have a transplantation of the lung who had normal alpha-1 antitrypsin to compare with, and these are the transplant cases, 36 of them, that you notice have a very, very, very low FEV1. And we use 28 controls, if you want, smokers with fairly normal pulmonary function test. You can see the FEV1 98%, and non-smokers, obviously, who had a normal pulmonary function test. We really wanted to see if there was a difference in the inflammatory pattern of these people, the alpha-1 antitrypsin, with controlling against the normal, usual COPD, and how did that do with the smokers. Now, the first thing we were interested in looking at was the lymphoid follicles in the lung, because the lymphoid follicles really can have an extremely important role in the adaptive immune response, and we know that they are important for the initiation of an adaptive response and also regulation of peripheral tolerance. So that we study, the other thing is that we know that these are found at sites of chronic inflammation and autoimmune diseases. Interestingly enough, when they are found in viral infections, they have a protective effect. However, when they are found in areas of immune disease, then they can really be very destructive because facilitate the activation of autoreactive T cells. Now, one thing that's very important is that this is the results that we found in our cases. You see that we knew that people with severe COPD have a lot of lymphoid follicles compared to smokers with no COPD. But you see, look at this alpha-1 antitrypsin deficiency. They have even more than the normal, than the usual COPD, and they can be found, as you can see, in the parenchyma around a pulmonary artery or around an airway. And interestingly enough, in order to see if those things were really directed towards something, we tried to use, we studied the clonality of the B cells in these lymphoid follicles, and found in 3 patients with alpha-1 antitrypsin, in 3 patients with COPD, usual COPD, and we found that in all of them, and this is kind of, this is the B-cell receptor clonality, and you see that they are either very oliclonal or monoclonal, meaning that they are reacting against one or very precise antigens. We did find that there were certainly no bacterial antigens in these lymphoid follicles, so really there is other antigens involved in there. Another thing that is controlled by alpha-1 antitrypsin and is extremely important, the initiation and maintenance of the immune reaction, is the IL-32. And you can see again in here what happens with the level of IL-32 in the deficient alpha-1 and in the usual COPD, both of them are very, very high. And you can see that the smoker with normal disease, they have a huge range, supposedly, meaning that there are different levels of inflammation in these smokers. IL-32 was found in not only in the macrophages and some of the cells in the alveolar wall, but especially so in the lymphoid follicles, as you can see. Another abnormality that we found that is controlled very much by the cell by alpha-1 antitrypsin, and this was only done interestingly enough in usual COPD, but we expect that the same thing will happen in alpha-1 antitrypsin, is the increase of BAFF, BAFFF, that means B-cell activating factor. So these B cells are really representing that, and again, this is controlled by alpha-1 antitrypsin that might be non-existent. So not surprising, B cells are increased in the alveolar wall of these patients compared to smokers and non-smokers. And as you would expect, we found the same thing in CD4s, that they are very much increased over the smokers and normals, and similar to the usual COPD, and the same thing happened with the CD8. So we have really a very important adaptive inflammation in alpha-1 antitrypsin that is similar to the one we see in usual COPD. This is the innate response, and you can see that there are no differences in the neutrophils and the macrophages, but again, the neutrophils, there are about 8 cells per millimeter, while the adaptive immune response cells were around in the range of 4. So there are plenty of neutrophils in the lung in these cases. So it seems like alpha-1 antitrypsin is going to really prevent the defenses that these people have in order to develop what it seems to be an adaptive reaction, because as we saw, we cannot control the dendritic cells, we cannot increase the T regulatory cells, we cannot stop the lymphocytes to proliferate, and if doing so, obviously we are going to end up, as we described with Alvar and Marina in the New England, about how this will then, with the B cells, T cells, and CD8, end up with a tissue destruction and COPD and produce the disease. However, and here we go back to you, only a few of these people develop this disease. So we cannot, so we have to go another level, if you want, in your scheme down, or up, if you want, is that what are the other factors? Obviously, there is going to be some factors that are going to promote the development of these abnormalities in some cases and not in others. And these are probably going to be genetics or epigenetic. So that's We really have to expand that any farther. Now, one thing that's important is that, as you mentioned very nicely, I thought, is that here there are the genes of asthma, but if we, choose this gene that might not be related really to asthma, then we're not going to find anything. Well, it might be, they say that we should find the genes in order to look at genomic studies for the disease based on the pathophysiology of the disease. We have been looking in COPD for genes, looking into elastics, anti-elastics, oxidation, and many other things around that have not really given so much of an answer. But so, it might be worthwhile to look at it again and see if we find something else. And just to conclude, I think that the mechanism of emphysema and alpha-1 antitrypsin deficiency go far beyond the antiprotease deficiency as we've been believing so far, or considering so far, that an adaptive immune response, possibly autoimmune, and facilitated by the lack of the alpha-1 antitrypsin anti-inflammatory function is the likely mechanism. That not all ATT cases develop the disease, indicating that other susceptibility modifiers, likely genetic, are really needed in order to develop the disease. And again, I think that to us this is very important, since the approach to select candidate-modifying genes is based in the pathophysiology of the disease. The investigation of genetic determinants of autoimmunity and tolerance in COPD with or without alpha-1 antitrypsin might be very revealing in order to understand better the disease. And finally, the question that we are asking and you are asking, I suppose, is the use of the alpha-1 antitrypsin as an anti-inflammatory medication in COPD with and without alpha-1 antitrypsin and asthma a possibility? Because it certainly is being used now in cystic fibrosis with some success. And there is something that we really, I think, we should consider very seriously in the future. Thank you very much for your attention.
Thank you very much, Manuel, for this new data and very stimulating hypothesis. I think there are at least a couple of questions. We can start immediately. Bill?
Yeah, Manuel, I fully accept I mean, again, Rob Stockley's been saying this for some time, the pro-inflammatory or anti-inflammatory effect of alpha-1 antitrypsin, and it's very interesting that it looks as though an autoimmune aspect may be important there. But this business of, alpha-1 antitrypsin occurring, or the disease emphysema occurring in only a relatively small group of individuals, is that not environmental? I mean, the old idea, you need the trigger, you need cigarette smoking, or you need infection in childhood, or something else. And if you don't have that, you don't really develop the disease, except you might develop a little bit of emphysema in your life because of air pollution and all the other things that we're exposed to. Is that out the window now? Is that? I mean, I can understand why this comes in at that point, but is that not the reason that?
I mentioned in the second slide and so on that certainly the risk factors, the main risk factors for this are smoking and male. Okay, in several papers in which they study the possibility of pollution and so on, they have not found really anything. They found that pneumonias seem to be, it might be a factor. The problem to me is that not having the inflammatory counterpart of or anti-inflammatory of alpha-1 antitrypsin, I don't know what comes first, either alpha-1 antitrypsin and then the pneumonia or vice versa. Okay, now there is beautiful data showing that in smokers, index cases, or cases that present with alpha-1 antitrypsin, okay, and have disease, and they smoke, the variation of the fall of FEV1 per year can go from about 40 to 150, 163, that's the maximum per year, millimeters per year. So not everybody does the same thing, okay? Now, in the non-index cases, meaning the cases that you find screening or something or another, the smokers do well. The smokers live much longer and die much less than in the index cases. So, there is not, sure that smoking is by far the biggest risk factor. But again, as we were talking about, you need many, many other things. You mean, obviously the anti-elastics is more important if we think about the destruction of the lung that might give antigens, but then you have to react to this or not to these antigens, and that's where, obviously once you get the disease, the smoker who has a propensity to develop the adaptive immune response, those guys by 30 years are dead, because then they have no defense whatsoever.
Yeah, thanks. Peter?
Just a quick thing, Manuel, really sort of following on what Bill said. Looking at your pathology and the other data that you've got, was there any sort of variation across the groups, particularly the two transplant groups, in terms of use of inhaled steroids or evidence of lower respiratory tract colonization? Each of them has been proposed as other variables that might change the immunopathology within the lungs. I just wonder if that was a factor in this particular group of people.
I don't know the details, but I think that they were both groups, transplanted and non-transplanted.
They were all checked for these bacterial or viral infections by our collaborator in immunology and pathology. Some of them had some viral infection, exactly the same in the two groups. And they were exactly at the same stage of the disease, like very end stage of the disease, going to transplantation. Said they were doing all sorts of kind of inhaled therapy, but exactly the same in the two groups. But they were so severe that there was no difference. The severity was exactly the same, also in clinical aspects.
Because that's a little bit different from what Jim was saying with the lung volume reduction specimens. And I think it's actually quite interesting to draw that reflection. It makes you think about what other factors, what Manuel's been saying, about what other factors are operative.
Yeah, the only thing we can say is that when we look at the clonality and what was in the lymphoid follicles, there were no bacterial antigens, and Dirkie in her publication in alpha-1 in lymphoid follicles, that I think was the first one who really brought the attention to this, she found no viral or bacterial antigens in these things. So they really, as much as we can, we have excluded at least that there was a reaction to these antigens in this one.
The last one. Alvaro.
Yeah, very nice presentation, Manuel. It's only a comment. I think that this is a beautiful example of what I said in one of the slides. You have genes, you have environment, and you have a phenotype. But in between, you have these networks. And the network may be many different things. Think about the network of a fisherman. I mean, the plasticity of the network is extraordinary. They break the network only they found kind of a rock in the bottom of the sea, and then they get there. But if not, the network adapts. So I think it makes complete sense to think, okay, you get the gene, you might smoke or not, but depending on many other things that might change with time, does not need to be one epigenetic thing. Might be a combination of things you develop or not the phenotype.
Yeah. But, again, exactly, that's why I wanted to present this after your presentation, because I thought it was really a link in there. But again, we really need to get as much data, I mean, biological data and clinical data as possible. And that should drive the genetic investigation.
It's not only that you need to get data, you have to get a lot of data, but then you have to integrate the data. Yeah, that's challenging.
Absolutely, but in order to integrate data, you have to have data first.
We apologize. We have to move. Thanks again, Manuel.